Good morning, friends. I'll start my topic given to me. So basically, the ablation and thyroid artery embolization for benign thyroid nodules. So thyroid nodules are very common. If we do the ultrasound, 10 out of 7, 7 out of 10 people will have some thyroid nodules. But the bigger nodules that are causing clinical problems, either it is related to the cosmetic bulge in the neck or pressure symptoms, vague lump feeling in the neck, respiratory difficulty in swallowing, or in the malignancy. So I'll focus mostly on the benign causes. And most of the time in my clinical practice, I have seen that it is either the cosmetic problem or some vague discomfort. Also, the bigger nodules with multinodular goiters, it is the compressive symptoms. So gold standard of the thyroid nodules is usually the hemithyroidectomy, but it has some drawbacks: scar, anesthesia, voice change, hypothyroidism, hypoparathyroidism. And surgical techniques has also improved, doing to prevent the scar, trans-axillary approach, robotic approach, or trans-oral approach for removing the thyroid. But these are not that cost effective, and it needs a lot of expertise also. So I start with the conclusion of my talk that in 2022, various disciplinary, the endocrinologists, the Head and Neck Society, the Thyroid Nodule Society, they have combined and made a recommendation that ultrasound-guided ablation procedures as a first-line alternative to surgery for patients can be given to them, those who have benign thyroid nodules causing compressive or cosmetic symptoms. So at present, it is a first-line alternative, but I am pretty sure that within few years, it will become a primary treatment for thyroid nodules. So what are the indications for thyroid? So the patient should be symptomatic, and usually the indications according to the various guidelines, the volume should be more than 20 if it is non-functioning benign thyroid nodules. Those who have cosmetic and local symptoms. Also, it can be done with autonomously functioning thyroid nodules, where you can actually burn the hyperfunctioning nodules and make the patient euthyroid. There is some role in the recurrent thyroid cancers as well as the micro cancers, papillary cancer also. There is some role is coming up, but it is controversial. So how to select the patient? So of course, patient should have symptoms. At least 2 FNAC diagnosis should prove that it is a benign. You should note down the ultrasound features, solid, cystic, and of course the thyroid scoring, symptom score, cosmetic score. So if it is low thyroids 1, 2, single FNA is sufficient. If it is more of a solid 3, 4, then at least 2 FNA should be done to prove that it is a benign. For autonomically functioning toxic nodules, single FNAC is sufficient. So basically, it was introduced in 2006. You know the mechanism of radiofrequency ablation, the alternating electric current causing anionic oscillation, frictional heats, and that kills the tumor. So this is a tumor nodule. After ablation, it has become so small that it is barely perceptible. And of course, as the advent of microwave in various tumors, it has also come up. The heat sink phenomena is less, but more or less results will be same. We will discuss in later. So chemical ablation by thyroid means cystic nodules are treated by alcohol ablation for a very long time before the thermal ablation has come. So it has still a role. How to select which patients require thermal ablation and which require chemical ablation. So if it is more or less purely cystic, ethanol ablation is the treatment of choice if the solid volume is 0 to 10%. If it is mixed, means 10 to 50% of solid part, then combining the alcohol ablation along with the thermal ablation. If it is solid, pure thermal ablation will be beneficial. So this is the usual position I prefer. You can do whatever you, because here your both hands are free. Patient is also comfortable, and you can approach all parts of the thyroid in one go. Here is the foot switch where you can control the ablation parts. So coming to the technique, what we have to do is the procedure should be safe. To prevent the adjacent structure, you need to do the hydrodissection. You have to create a fluid around the thyroid nodule so that you can burn it, so that heat doesn't cause harm to adjacent structures. And in this diagram, you can see the yellow triangle here named D. This is called the danger triangle because this is the usual location of the recurrent laryngeal nerve. And on the left side, it is close to the esophagus. So hydrodissection basically displaces the recurrent laryngeal nerve and esophagus so that the complications becomes less. Also, on the lateral part also there are various vessels, also the vagus nerve, sympathetic ganglion, that also should be saved. And creating a hydrodissection is far more easy in thyroid area as compared to where we do it in the lung or liver nodule. So you can see very clearly that how easily the hydrodissection is created. You can see whole of the nodule is getting elevated. Entering the antenna, there are two approaches, transisthmic or lateral. According to the literature, medial or transisthmic approach is preferred because you are away from the danger area. But with experience, both the approaches can be easily done. So how it is done? The technique is called the moving shot technique. So it is ablated in small areas of about 8 millimeter or 9 millimeter, not like liver where you put the RFA in or microwave in the center and ablate the whole thing. So small nodules, small areas of ablation are created, and you have to cover up the whole of the nodule. So 30 to 40 watts is usually you have to set your machine, and a particular area is ablated for 10 seconds. And again, you see the air bubbles as we see in the liver ablation. The air bubbles forms, and we are clear that that area is ablated. So you have to cover the whole of the area. And again, the moving shot technique is required. For solid cystic, what we have to do is first place the microwave antenna in the center, then place another needle, aspirate the cystic component, do the alcohol ablation, and after aspiration, alcohol instilled, wait for dwelling time of 5 minutes, and then thermal ablation of the solid part, and the wall of the cystic lesion is done. Follow up. So it's a daycare procedure. Usually we send the patient within 6 hours, telephonic interview, next day, 1-month visit for thyroid function test and to see the regression of the nodules and relief in symptoms at 3 months, 6 months. So this is before procedure, and this is, you can see how it has become significantly reduced. And this is the clinical picture. You can see complete disappearance of the swelling of the neck. So another case, big nodule and swelling in the neck, and you can also use the contrast in ultrasound to be sure that whole of the ablation is done. Again, moving shot technique, whole 5 minutes ablation, and you can see whole of the area is, the appearance has changed, and confirmed it on contrast ultrasound to make sure that whole of the area is ablated. And this, you can see the significant change in the size of the swelling. Complications, very less. Recurrent laryngeal nerve injury is reported in 1% of the case in the form of voice change. If it occurs, give steroid for 5 to 7 days in a tapering manner. And most of the time, the voice recovery, even it has happened in one of my case, usually comes back in 1 to 3 months. Hematomas, just compression, pain during the procedure is sometimes a problem, but we don't do the procedure under GA, general anesthesia, or very high sedation, because we want patient to tell us that he's having discomfort. So we are sure that, so we know that some problem is going on. When the heat is within the thyroid nodule, patient doesn't feel any pain. If we see the literature results, the volume reduction rate is ranging from 84% approximately in most of the studies, and more than 50% volume reduction is seen in 91% of the cases, and many of the nodules also disappears. Whether we require another session or not, so basically those nodules who have bigger nodules more than 20 mm might require another session, or if the clinical problems is not resolved. If we compare with the surgery, so this is a comparative surgery. There we have seen the response rate was nearly equal in both the procedures. However, the complications were higher in surgery, 6% versus 1%. And also the hypothyroidism was significantly high in patients after surgery and very less in after the ablation, because we are not removing the normal tissue. So microwave ablation has also made its space in thyroid ablation, and our results are equivalent to radio frequency ablation. So we can say that it is a safe and effective treatment. Proper planning is important, and of course, hydrodissection is very important. Many people don't do the hydro, but it is really helpful in complete ablation of the entire nodule margin, because these are the margins which are the cause of regrowth in long term, let's say 4 or 5 years, that the cosmetic problem again comes back. So try to complete ablate the nodules. Now, what about the nodules which are very big, more than 20 or even more than 100, or the multinodular goiter, retrosternal goiter? So here the ablation possibly will not be that effective, because 20 cc is the usual volume where we can ablate in one session. What about the bigger nodules? So again, the surgery is the gold standard. Patients who have retrosternal goiter, surgery is definitely associated with higher complication rate in the form of recurrent laryngeal nerve injury, hypothyroidism, hypoparathyroidism, and the mortality rate is also there, even if it is going retrosternally as compared to the cervical goiter. So if the nodule is more than 20 or 30 cc, it will be more time consuming. Multiple sessions may be required. As you can see this in study, if it is more than nodules, number of sessions were significantly high, and the overall volume reduction rate, if it goes above 30 cc, the volume reduction rate is also less. So and it is very cumbersome for the patient to every 1 month or 3 months come for 2 or 3 settings, and the cost effectiveness doesn't allow this. So thyroid artery embolization helps because it has higher volume reduction if there is a big prominent nodule on the one lobe, or it is a multinodular goiter. So very less studies have described this. This is a latest article where they have done the large solitary symptomatic nodules through transradial approach. And for multinodular and bigger nodules, the radioactive iodine has been traditionally used, but it can lead to the hypothyroidism and retrosternal goiter. As I have discussed, the radioactive iodine is usually not successful, and surgery is the only effective treatment which has high morbidity. So if we see the history of thyroid embolization, it is used in 2002, 2007 article. You can see the thyroid artery embolization is used for control of the symptoms of the Graves' disease. And there people have shown that in both these studies, the volume reduction was there in terms of 30 to 50% in 6 months. So people become curious, and there is a lot of literature available on the Graves' disease control. So for these patients, how to select this? So patients in this study, they have taken the dominant large nodule more than 20 with solid portion, who are symptomatic, and taken the all the parameters that I have discussed. So coming to the anatomy, we all know the superior thyroid artery arises from external carotid artery, and the inferior thyroid artery comes from the thyrocervical trunk. In 10% of the cases, there is a direct artery to the inferior part of the thyroid, which is called the thyroid artery. It is seen in 10% of the cases. It arises from either from the right common carotid or innominate artery. What about the particle size? So usually for superior thyroid artery, 350 to 500 is recommended, because they can have communication with the ICA. So you want to use the bigger particles. For inferior, smaller particles can be used. And so best agents in this study, they have recommended 350 to 500 particles. And what they have recommended is embolize 2 or 3 arteries to prevent the hypoparathyroidism. Leave one artery definitely, so that it will take care of the functions in the future. And endpoint is the classical embolization, 6 cycles, stagnation. And of course, the cone beam CT also helps in seeing that we have covered the whole of the area and non-target embolization. This is, I will take some time here. So these patients, when we embolize the thyroid tissue, it leads to the release of thyroxine hormone, and even clinical and subclinical thyrotoxicosis is seen in many of the patients. So what we do is that we give steroids, 8 milligram IV OD on the day of the procedure, and then 4 milligram ODs for 4 to 5 days. Also, the beta blocker is given to reduce the symptoms of hyperparathyroidism. We start it 1 or 2 days prior to the procedure. And after that, we give neomerconazole, which is basically anti-thyroid medications to take care of the thyrotoxicosis. And patients are sent with steroids and beta blocker and anti-thyroid, and follow up as usual of any ablation. So this study, the 6 patients, they have shown that 3 months volume reduction was 86%, 92%. So very good volume reduction rate. And also the appearance score, the VAS score is also, and no significant complication they have mentioned. And they have used the pushable coils after injecting the PBA, which is a controversial topic I will come to later. So image from that article, the volume was 170 at 1 month. And this is after 6 months, significant reduction, and even the retrosternal part has significantly decreased. They have used the PVA along with the coils in their cases. So this is the largest study available for thyroid artery embolization, where they have done the 56 cases. They have divided into 2 groups. Group A is where only one side a predominant nodule, and group B, which consists of 36 patients, where it is a multinodular goiter. And many of the patients have intrathoracic extension. Also, many of the multinodular goiter were hyperthyroidism at the time of enrolling in the study. And they have used the PVA particles. Again, they have used the coils in initial patients, but they stopped because we know the concept that we should not block the parent artery, so that we can treat it in the later part. And they have shown a very good response rate in the volume reduction, the intrathoracic extension part, the hyperthyroid score. So the patients, many of the patients become euthyroid after the embolization. And not much complications. One patient had blurred vision, hoarseness of voice, groin hematoma. So no very significant complications. So basically, that in their study, their trans-arterial embolization leads to a reduction of 69%, which is comparable to percutaneous ablation for small nodules. But these are the bigger nodules, and where the ablation might not be that effective. So these are the cases. You can see the significant reduction in size as well as the enhancement. So we have recently started about 1 year back. We have done about 12 cases, and we have a mean follow-up of just 3 months, not much, but we know that hyperthyroidism after the procedure, especially after 48 to 72 hours, is problematic, and we have to pre-medicate the patients properly to control their symptoms. And these usually results in about a week. So the patient's complaint of weakness, lethargy, and sometimes hot flushes they feel, so which can be controlled by the pre-medications. So one patient had a transient memory loss, and we have done the MRI. That has shown the possibly the undefined collaterals. The particles have gone into the cerebellum, and it recovered in about 5 to 7 days. So we also got the similar type of response with good improvement in the score till the follow-up. So just to show a case, a big swelling, bilateral nodules in both the sides, and you can see the trachea is shifted towards the left side. Big nodule. We have gone into the inferior thyroid. This is the superior thyroid. Mostly it is supplied by the inferior thyroid, and we have done the embolization. This is the inferior thyroid end embolization, and this is the superior thyroid end embolization image. And this is the response. You can see there is significant reduction in the overall appearance. So with this, I conclude my talk that these procedures are very effective in overall treating the benign condition of the thyroid, and possibly they will become soon a first line therapy. Thank you.